Nick, and thank you very much to Helen and the team for inviting me to be here today. I apologise that I've not got the clothes on that I would like to be wearing because I've got an arm in a sling. I had a fracture dislocation of my shoulder whilst doing some childcare about 5 weeks ago, which is fine, but I apologise for how I look. It's not how I would normally be. So I'm speaking to you today in my capacity. Nick has talked about all my different roles, one of which is as a trustee of the association, and I am vice chair here. I am speaking to you today as clinical lead for the Outpatient Recovery and Transformation Programme to try and tell you what you can expect around transformation in dermatology services, which I hope are going to work to your advantage. So essentially, I'm going to summarize through this short presentation, and I don't think I need to tell you why we need to do things differently. There will be many of you in the room or attending the conference who have had a terrible experience of trying to access specialist services over the last few years. We need to change it. We need to make it better. So I'm going to talk about how we're trying to do that through the Outpatient Transformation Programme, which is now called the Outpatient Recovery and Transformation Programme. I'm delighted that the Psoriasis Association have been hugely involved in this work and have had a big voice in developing and supporting the new pathways of and will take forward the implementation with us as well, we hope. I'll talk to you about what those new pathways will look like for you personally if you need to access care for psoriasis, if you have psoriasis. And I'm going to try and give you a timeline and manage your expectations around when these changes will come into place. So I do apologise for the font as well. We downloaded a slightly modified presentation, and Birmingham has obviously introduced a new font as it was downloaded, and we didn't have time to reorganise it. So it's a little bit fine and not quite my usual font, but I'm assured that you can all read it. So what you need to understand for me as a dermatologist in Lincolnshire, I get two very clear types of referrals to me. One of them is skin lesions for diagnosis and management, and is it skin cancer, is it not? And the other half of my work is around inflammatory skin conditions, of which we are talking psoriasis, eczema, and acne. So it's people with those conditions. Now, what many of you will be aware of is that over the last 20 years, we have had an emphasis on what is called the 2-week wait suspected skin cancer pathway. And essentially, it has been possible for primary care clinicians, GPs, to refer in patients on a rapid access 2-week wait pathway to say, has this patient got skin cancer or have they not? And this has had a massive impact on dermatology services because we have had to meet those 2-week wait referral targets. And as a result, people with psoriasis, eczema, and acne have often had their appointments cancelled and have had to wait much longer because of the skin cancer activity. So we need to redesign our whole pathways, everything. We need to look at how we can transform the way that patients are referred for care for skin lesions and for inflammatory skin diseases. We have to have a pan-system approach in order to make this work and make it better for everybody. So as I've said, currently, if you had a funny looking spot which was completely innocent, for example, the one that on the 2-week wait referral there, that's a benign lesion. If your primary care clinician was slightly anxious about that, that could be seen on a 2-week wait referral pathway. The patient would come in to be seen, and what might well happen is that if you've got a long-standing appointment, new patient appointment to be seen with your psoriasis, that might well be cancelled in order for me to see that patient. Now, the problem is that 96% of all of our 2-week wait suspected skin cancer referrals are benign, non-relevant lesions. So that's dreadful for you people with psoriasis, because what that's about is that our appointments are being used up for people who actually perhaps don't need to come, and people that do need to come are not being accommodated in a timely fashion. So the Outpatient Recovery and Transformation Programme is what I'm going to talk to you about, and the work that we're trying to do to remodel and reframe the way that people are referred. So the vision of this programme is to try and personalise care, and that's actually at the centre of the NHS plan that was published in 2019. It's about personalising care, challenging at the moment in the context of the elective recovery activity. Greater patient choice. We need to meet different people's needs. So for example, if we're going to use technology, we need to remember that some people might not want to use technology, might not want to use digital imaging, teledermatology, and so on. So we need to meet everybody's different and individual needs. We need to see people at the right time. So if you've got very bad widespread psoriasis, you shouldn't be sitting on a waiting list, and you shouldn't be cancelled for somebody who has a benign skin lesion. We've got to get that reorganised. And we do need to embrace technology. And I think there are opportunities within dermatology to embrace technology. So what about the dermatology work stream for the Outpatient Transformation Programme? Well, myself and Dr. Emma LaRue, who's a GP and also works in dermatology, we were appointed in the autumn of 2020 to work with NHS England and Improvement on outpatient transformation for dermatology. We developed an advisory group. Throughout everything that I've ever done in my career in working in redesigning services, I've always felt there is no point as clinicians trying to decide how things should work. It's actually got to be from the patient's perspective. So the first thing that Emma LaRue and I did was to establish an advisory group, and core membership of that advisory group was from the patient organisations and from other patients as well. And as ever, Helen and her team were very, very much involved in representing the views of people with psoriasis throughout this whole process. Time-consuming, and lots of work, but really, really engaged. So I'm optimistic that what we have come up with does reflect on what people with psoriasis need. We, of course, needed the specialist organisations on board. So we had the British Association of Dermatologists, our specialist nursing colleagues represented by the BDNG, GPs, from the Primary Care Dermatology Society. And of course, we needed to link in with other NHS agencies, including NHS Digital, who is responsible for looking at digital transformation within the NHS. So what did we do? We looked at some of the generic documents that were out there. There was some generic guidance around remote consultations, for example, which we had to take on board. So we looked at what was out there already. We then spoke to our stakeholders, in particular our patient groups, and said, for example, if we take our work on telephone and video consultations, what we did was we went out to our patient groups and said, look, if you're a patient, when do you want to have a telephone consultation? How do you think remote consultations can work? Patient-initiated follow-up, which I'm going to speak about, how can that work best for you? So we came up with our first draft of our guidance, very much based on interaction with our patient organisations. We then collaborated. So we took on board the views of our patients first, and then we shared it with our specialist organisations and said, this is what our patients want. What do you think? Can this work? And then came up with our draft guidance documents. And we have now they've been held up because of the COVID. All of the publications have been held up very significantly, but we are about to launch these within the next 2 weeks. So how's it going to affect you? That's what you want to know. So I'm going to talk about 3 areas that I think will be relevant for you. And I'm going to start with patient-initiated follow-up, which some of you may already recognise as already having patient-initiated follow-up by a different name. So patient-initiated follow-ups are basically what we tried to do. What we've always tried to do in our department is that if you've got psoriasis and you have a course of phototherapy, the challenge has always been that at the end of the phototherapy, you're better, and we discharge you. How do you re-access the service? That's always been a challenge. And historically, we were able to give you an open appointment. So you could ring up and you could say, oh, I'm Mrs. Brown, I've got my psoriasis has flared, can I come back? And that was fine. But with all of the various changes in the NHS over the last 20 or 30 years, that's become increasingly difficult. And what's happened is that many people in that situation have had to be re-referred and go back onto a waiting list. And that's just not fair. So we need to do that differently. So there's lots of you may know what I'm talking about. This is open access, follow-up, etc. But we're formalizing it. We're going to call it something proper, and you're all going to be eligible to ask for patient-initiated follow-up. So basically, the idea is that you will have a trip to an outpatient appointment and be seen when you need it, not when you're well and all is fine. So the idea would be that when I see somebody who's doing well and their psoriasis is better, and they say, I'm clear, but they say, but I know in the winter or next year, or if I move house, it may get worse. How can I come back and see you? We would have the discussion with you or a carer. If it's a child, we can do this with the carers as well. And we would agree to put you onto what's called a PIFU pathway. Different organizations will organize this differently. So basically, I would give you an information sheet with some details about how to re-access the service. But the really great thing that we've been able to negotiate is that this PIFU pathway can be up to 5 years. So that is so much better than what it used to be. We used to be able to say you can re-access within 6 months, otherwise you'll need a new referral letter. And in actual fact, that's what our local hospital wanted to do. 3 or 6 months, Dr. Schofield, that will be fine. To which we said, absolutely not. And obviously Helen and the Psoriasis Association representation said, well, that's no use. We need longer. So you can be on a PIFU pathway for 5 years. So again, this is something you need to know about if you're being offered a PIFU in an organization or a specialist service that you are a patient with. So basically, the idea is that it's an alternative to your regular follow-up appointment. You are given a number to contact to re-access the service as you need it. And Emma, as a GP, was really, really excited about this idea because she said what patients do is they get very frustrated if they cannot re-access the care from a specialist, and they ring GPs and they're on the phone to the GP the whole time. And that's actually no good for you. It's no good for primary care. So the idea is you will be able to re-access care as and when you need it. So when should you have this? 80% of departments around the country have some form of PIFU in place. This is now. It was published with the personalised care documentation 2 or 3 months ago, the whole concept of PIFU, the generic documentation, but the actual dermatology specific guidance will be published within the next couple of weeks, but it is already being implemented. Our documents are coming out a little bit after we've started implementation of some of our pathways. Okay, I'm going to speak next about it says there, video consultations, but I'm going to talk about the broader issue of remote consultations. Let's be clear what we mean. There's a lot of misunderstanding about what we're meaning about remote consultations. So what we talk about in our guidance is a telephone or a video consultation. Many of you may well have had both types of those consultations during the pandemic when we reduced our face-to-face activity. And indeed, the Psoriasis Association was involved in a really important piece of work, finding out the opinions of people of how that worked for them. And that really, really was very powerful information when we were trying to develop our guidance around this. Now, dermatology is a very visual specialty. Apparently, we're all good map readers and we can do jigsaws. We're visual people. We need to see people to look at their rashes, to make diagnoses, and that's quite important. So what we found out during the pandemic and with the help of our patient groups is that, yes, telephone and video consultations help us, but we need to be absolutely clear which group of patients they are useful for. So for example, if you've got melanoma, which is a skin cancer, and you need your skin to be checked and your lymph nodes examined, I can't do that over the phone or via a video consultation. However, if you are on methotrexate for psoriasis and have been stable on methotrexate for many years, a telephone consultation will work really well for you by one of our specialist nurses, perhaps. But if your psoriasis flares and you want to talk to me, I need to be able to see you and you need to be able to come. So it's not one size fits all, and that's really, really important. And we had a target after COVID, which was that 25% of all outpatient activity across all specialties had to be telephone or video consultations. And we pushed back on this big time. If you're a new patient with psoriasis, you probably will want to come and have a conversation and develop a relationship with your clinician. And indeed, we have managed to negotiate something slightly different, which is around probably 25 or 30% of our follow-up activity will be delivered in this way. And the slide just summarizes what I've been saying, which is that we are largely a visual specialty. So remote consultations are best suited to people with stable disease, is our view, and that was the view that was supported by the questionnaire in the paper that was published that the Psoriasis Association was involved with. You should be able to choose, and that's really important. If somebody says to you, you can't be seen, you have to have a phone consultation, you don't have to do that. It's your choice, and that's important. And the video consultation is too. And the video consultation is important. If you've got flexural psoriasis in an intimate area, such as on the genital skin, it is completely inappropriate for that to be a remote video consultation. So we have tried to fight the corner for our patients with psoriasis so that you are able to have proper face-to-face consultations when you need them. And this is just a summary of what we have to think about. I'm not going to go through it in detail, but it basically asks the question, who is it appropriate for? Who are remote or consultations appropriate for? These are the sort of showstopper things that we need to think about. And you'll see in quite a lot of situations, a face-to-face consultation is more appropriate. But we need to free up the capacity to be able to see those people who want to come and be seen. So you'll already be aware, many of you, and I think the problem with this remote consultation issue is that it's well engaged, it's in there, it's implemented, and we're having to push back and say, actually, this is not right for me. I want to be seen face to face. Now, the final thing, which is I'm going to talk about, which is a little bit more complicated, but is really, really important, is called referral optimization. So what do we mean by referral optimization? So what that means is, what I'm trying to get at is that we shouldn't be seeing a lot of patients with benign skin lesions and cancelling people who have got widespread inflammatory skin disease who require an urgent face-to-face appointment. So the process of referral between the GP and the secondary care service needs to improve so that the right people are prioritised to be seen in the right time. So I'm going to remind you of a pathway which will be familiar to many of you. So you go, this is an example of a patient that Emma LaRue, my colleague, had, a 46-year-old lady. She's known to have psoriasis. She works in a supermarket. She's got some cracking and fissuring of her palms. This is a flare-up of her psoriasis. Lots of primary care clinicians have seen her. As you know, a lot of the advanced care practitioners now are seeing patients in primary care because of the shortage of the GP workforce. She's tried a lot of treatments and she's getting nowhere. So what used to happen was a referral would be made, and even if that, and then that referral might be marked urgent or routine by myself as the specialist. She would be signed off work. She was signed off work for a long time, and an urgent appointment at the current time might well be several months. That might be cancelled if we have a 2-week wait target patient that needs to be slotted in. Eventually, she's seen in outpatients, she's referred for phototherapy, and there's a long waiting list for that. So basically, this is not satisfactory. The patient's miserable and off work. It's no good at all. So we have a new system, which you need to be aware of, which is called advice and guidance. And this is due to be the front door to all dermatology specialist services and is already happening in large numbers of departments around the country. And it is transforming the way that we work. So we have a hot week arrangement when we have a specialist who looks at what are called advice and guidance referrals from the GP. So you go to the GP sees that you've got a very bad flare of your psoriasis, might request that you send some photographs in or might take some pictures. The GP sends in an advice and guidance request, which is a bit of text and a bit of pictures, hopefully. And that goes into the specialist who's on the hot week looking at these advice and guidance referrals. And then that will be triaged. So if you've got a little bit of psoriasis on your elbows and nothing else, the consultant will write back and say, try some Enstellar foam. If you're covered in psoriasis and it's terrible, the consultant will say, book onto our urgent hot week clinic and you'll come up at the right time. So that's the idea of the new system. And in parts of the country where this is fully implemented, it has transformed access to care for people with skin disease because you are triaged appropriately and seen at the right time. So the new pathway would be that the GP would write in and say, this lady's off work, it's all terrible, and the advice and guidance interaction would be ticked, the box would be ticked so that it could be transferred into a referral, urgent dermatology clinic. Possibly this would be not maybe the same week, but maybe 2 to 4 weeks. And the phototherapy referral could be made at the same time as the advice and guidance request comes in. So the whole pathway is transformed. So this, as I said, is already in place and you will start to hear about it. And indeed, Helen and I had an interaction about how badly people have been doing lately with psoriasis in terms of getting seen. And my advice back to her has been they should be asking their primary care healthcare professional to send in an advice and guidance request, sending in some photographs of their skin, and that then means that the specialist can prioritize appropriately that referral. Okay, but we've still got to sort out all these skin lesions, haven't we? Because we've still got all these appointments, face-to-face appointments for people with skin lesions. So how are we going to deal with that? And we've got to deal with that as well. So what we've done with that, these skin lesion, patients with skin lesions lend themselves brilliantly to teledermatology. So we have set up some new skin lesion diagnostic pathways, the idea being that if you have a single skin lesion, you no longer go on a 2-week wait pathway and are seen face-to-face, which is not a good use often of time for people who are busy and working. These appointments are done virtually and they're done using images so that frees up capacity for the people that need to be seen face-to-face. We've developed a load of resources to try and encourage this. We're struggling because the GPs haven't got time to take pictures. So we're looking at developing community diagnostic centres. In the community diagnostic centres, we're looking to perhaps have them as image-taking centres. What about, there'll be some of you that were referred 2 years ago. So what are we doing about that? Because it's not fair, is it? If we have a new front door of advice and guidance and you present now, and you get seen quickly, it's not fair that if you were referred 2 years ago and you're sitting on a waiting list. So what are we doing about that? Well, we've also developed, along with all our stakeholders, a very clear statement around a recovery plan, which will involve validation of all of our waiting lists. And many of you will be contacted for a patient discussion, asking you whether you still want to come, how bad your skin is. We may ask you to send in photographs, and then we will prioritize and try and get you seen. And many people are being seen by private providers, and I don't have a problem with that. We can't see a lot of our long waiters, so we've got a private company that we're working very closely with to see the patients that are on our long waiting list. We've got very clear rules about, interactions between them and us, and they've got very high standards of care, which we have been looking at so that we're confident that our patients will be seen by good folks and get the right treatment. But we don't have the capacity now that we're business as usual to see the 3,000 patients we've got sitting on our waiting list. So we're trying to work at doing it a different way. We will probably, as I say, part of that prioritization exercise, if you're contacted, you may be asked to send in some photographs. And obviously, the reason we would ask you to do that is because we want to prioritize people who've got severe disease and get them in as quickly as possible. So if you had relatively mild disease, once again, we would probably write with some advice. And if you had severe disease, we would prioritize your appointment. So in summary, I'm really, really excited. I've been in dermatology for over 30 years now. I've worked with Helen and Nick for many years. We've looked at transforming and redesigning services previously. I think we've got fantastic opportunities now to do things better. And I'm really proud of what we've done together with our patient groups and the specialist organizations. And I'm really, really hoping that it's going to make things better for all of you people. Thank you.